and I specialize in breast cancer, currently in my role as an office practice nurse. So I would like to discuss with you about tamoxifen and their side effects and indication. I usually hear it referred to as tamoxifen, but they could also go by Soltamax here in the United States, or Tiva tamoxifen in Canada, or EPO Tamox. It is a SERM, which is short for selective estrogen um, receptor modulator, and it's used to treat estrogen positive breast cancer in men and women. It has changed the landscape of breast cancer treatments since its first introduction in the late 1960s. In the breast tissue, tamoxifen antagonistically competes with the estrogen receptor sites, and it causes a anti-estrogenic and anti-tumor effects. It is metabolized by the liver via the CYP450 enzyme and has a half-life of 5 to 7 days. It is then excreted in the feces. Tamoxifen should not be used in patients who are actively taking warfarin or who have experienced past thromboembolic events like deep vein thrombosis or pulmonary embolism. This medication has multiple drug-to-drug interaction, so it should also be avoided in patients already taking anti-estrogen medications like letrozole or anastrozole. Tamoxifen should also be avoided in pregnant women as there's the teratogenic effect, which can harm the fetus. Women should also avoid breastfeeding as they're actively taking this medication regimen, um, and also 3 months after completion of this drug. Tamoxifen is available in tablet form of 10 milligrams or 20 milligrams. It could also come in an oral solution as a 10 milligram per 5 milliliter solution. 30 tabs of 10 milligram tamoxifen would cost $12, while 30 tabs of 20 milligram tamoxifen can cost $19, according to Hippocrates. There are no dose adjustments necessary for patients with renal impairments. According to American Society of Clinical Oncology, the recommended dose for tamoxifen would be 20 milligrams daily to treat breast cancer and prevent future recurrence after receiving appropriate treatments. The duration for tamoxifen therapy depends on the menopausal status of these patients, so it could last maybe between 5 to 10 years. To treat metastatic breast cancer, it may be recommended for patients to take 20 to 40 milligrams daily. As healthcare professionals, we should teach patients about the black box warning and the adverse effects of this medication. Patients on tamoxifen should have routine lab works so we can check the complete blood counts, the serum calcium, and the liver function tests. Women should also monitor for any signs of vaginal bleeding, as it could be a sign for uterine or endometrial malignancies. Patients should also monitor for signs of DVT and PE. Common side effects of tamoxifen would be hot flashes, menstruation irregularities, and vaginal discharge. Other common adverse effects could be peripheral edema, hypertension, mood changes, skin changes like skin rashes, depression, nausea, vomiting, arthralgia, and pharyngitis. In patients who already have bone metastases, it could cause hypercalcemia. In patients who are taking anticoagulants, we need to check their PT and INR levels. Women at childbearing age should check for pregnancy status prior to starting this treatment, and they should be advised to have reliable birth control methods. Patients should also get a bone density exam and to have regular ophthalmic exams in case they have changes in their vision, like blurry visions or cataracts. If a patient were to experience these adverse side effects, then they should know to notify their medical provider or most likely their medical oncology team, because then they can consider switching them over to a different type of medication with the same anti-estrogen effect, such like a aromatase inhibitor like letrozole or exemestane. In this article I've read from the Journal of the National Cancer Institute, a secondary analysis has been done by Johansson and Company on a controlled randomized clinical trial called the Stockholm Tamoxifen trial, where there was a 20-year complete follow-up until December 31st, 2016. 3,930 participants in total were initially enrolled. Between 1976 and 1990, 1,226 participants were under the STO trial, where they consist of both pre and post-menopausal patients who have a positive node status with a tumor size of 30 millimeter or greater. 1,780 participants were under the STO3 trial, where it consists of postmenopausal women who are node negative with a tumor size less than 30 millimeter. In 1990 to 1997, 924 participants were under the STO5 trials and consist of premenopausal patients who are either node negative or node positive. The exclusion criteria include 130 patients who have previously been on goserelin, which is a synthetic hormone that acts as a gonadotropin-releasing hormone agonist, which had shown differential long-term treatment benefits. Premenopausal patients who have positive lymph nodes were treated with adjuvant chemotherapy, so they are also excluded from the study. The participants were further narrowed down and had to meet the inclusion criteria of being ER positive and HER2 negative tumors. 1,242 estrogen positive and HER2 negative patients, so that's comprising of 381 premenopausal patients with the average age of 46.6 and 861 postmenopausal patients with the average age of 61.2, were randomly assigned to 2 to 5 years of 40 milligrams of adjuvant tamoxifen or no endocrine therapy. Distant recurrence-free interval in tamoxifen treated versus endocrine untreated patients were assessed by Kaplan-Meier, Cox proportional hazardous regression, and time-varying analyses. The aim of the study is to see if there are any differences in the long-term benefit from tamoxifen therapy in premenopausal and postmenopausal estrogen positive and HER2 negative breast cancer patients. Analyses were done in R version 3.5.2 and the SAS version 9.4. All statistical tests were two-sided, and a p-value of less than 0.05 was considered statistically significant. In premenopausal patients, significant benefit was observed for lymph node negative, progesterone receptor positive, and genomic low-risk tumors, but only lasted about 10 years for genomic low-risk tumors. Postmenopausal patients showed long-term benefits for all good prognosis markers, including low-grade disease, lymph node negative, progesterone receptor positive, low Ki-67 levels, and genomic low-risk tumors. Premenopausal women with no poor prognosis characteristics showed early benefit and postmenopausal long-term benefit. The study suggests differential tamoxifen benefit depending on menopausal status. Differential tamoxifen therapy showed a significant long-term benefit in postmenopausal patients only. So there are some limitations to this study. It's difficult to compare the minimum of 2 years of 40 milligrams tamoxifen once daily given during the STO trial with the current treatment guidelines of at least 5 years of 20 milligrams dose of tamoxifen daily. As of today, the optimal dose and duration of endocrine therapy have yet to be determined and requires further research, which may also differ between premenopausal and postmenopausal patients. Thank you so much for listening and watching my video. I hope you learned a lot about tamoxifen.